Welcome. This is a UCLA Women and Philanthropy hosted conversation among accomplished UCLA experts. These panelists bring both research and experience about how community conditions and other factors play a powerful role in determining health and outcomes. I am Susan Rice, President of UCLA Women and Philanthropy. Women in Philanthropy at UCLA celebrates and inspires women's giving across the UCLA campus. Within and without, we foster women's participation in volunteer leadership positions, giving to UCLA of our time, talent, and our treasure. Our diverse membership gives all over the campus. Since its beginning, our extraordinary women leaders have served UCLA on departmental advisory councils, task forces, student mentoring, scholarship advisories on the University of California Board of Regents, and the UCLA Foundation Board. In 2019, we celebrated our 25th anniversary. I am proud to say that we are now over 3,000 women members strong. To engage the UCLA community, we hold events throughout the year that showcase different areas or topics across campus. Since COVID-19 hit our world, Women in Philanthropy has provided all events in this virtual format. We expect we'll be able to resume some programs in a live format in 2022. But we've been really delighted at the enormous and enthusiastic response to our virtual presentations. And tonight's going to be one of them. UCLA Women in Philanthropy welcomes the involvement in planning events to all of our members. We like to include the broadest and most diverse participation from you. We would be pleased to respond to any inquiry you may have. We like to think that bringing intellectual and emotional discussion broadens appreciation of UCLA by all of us. And now a few words about our program. We've got a great panel. They've come straight from the operating room or dealing with patients and have set aside time in this early evening for us. One of our panelists may join us at the very end, but she's been called to deal with a serious problem in the operating room. That is Rochelle Dicker, who is co-chair of Health Equity and Translational Social Science Research Theme. And she's also the co-director program for the advancement of surgical equity. And she's vice chair of critical care at UCLA and a professor of surgery and anesthesia. We hope that Dr. Dicker can join us later, but for now, she's not here with us. Before we begin, let me try to provide a bit of background on our topic, how social determinants contribute to health disparities, and understanding these can lead to healthy outcomes. Most of us understand things like heredity, age, and nutrition and how they impact our health. But social determinants like income inequality, language barriers, and housing instability have an even greater effect. Social determinants of health are the conditions in the environments where people are born, live, learn, work, play, worship, and age. They affect quality of life outcomes and a wide range of other health outcomes. Some examples include safe housing, transportation, neighborhoods, racism, discrimination, violence, education, job opportunities, and income, whether they have access to nutritious foods and physical activity opportunities, whether the air is polluted, or the water is polluted, and their language and literacy skills. To give one example, did you know that the life expectancy increases with income? More than 1/5 of people living in households earning less than $35,000 a year annually say their health is fair or poor, which is 4 times greater than what is reported by people living in households earning $100,000 or more. So our panel of experts from UCLA Health and the David Geffen School of Medicine at UCLA will share with us how community conditions and other factors play a powerful role in determining health outcomes, and what UCLA is doing to help improve the situation. Let me tell you about our panel. Besides Dr. Dicker, we will hear from Dr. Eraka Bath, Dr. Alejandra Casillas, and Dr. Lisa Nichols. Eraka Bath is the Vice Chair for Justice, Equity, Diversity, and Inclusion at the UCLA Neuropsychiatric Institute in the David Geffen School of Medicine, and an Associate Professor for Child and Adolescent Psychiatry. She has a longstanding interest in healthcare disparities, minority and community mental health, and with particular interest in addiction and trauma within the special populations of juvenile justice and foster care youth. Dr. Casillas, Alejandra Casillas, is an assistant professor of medicine in residence, general internal medicine, and health services research, and a primary care physician. Her research focuses on health inequities, and her studies examine how medical care access and interventions can be developed to improve the quality of life for minority and limited English-speaking populations. She has led research projects that focus on reproductive health, depression, and cognitive decline in minority populations. Lisa A. Nichols is the Vice Chair of Equity, Diversity, and Inclusion in the UCLA Obstetrics and Gynecology Division, and an Associate Clinical Professor of UCLA Obstetrics and Gynecology. She oversees the ongoing commitment in the area of equity, diversity, and inclusion that includes dedicated department support for the Department of Obstetrics and Gynecology at UCLA. I am thrilled we have been able to gather this amazing group of UCLA faculty members, and we'll stop talking now so that we can all hear from them. There will be time after their conversation for the panelists to answer questions from the audience, so please submit them through the Q&A function on the bottom of your Zoom screen. They will be viewed and consolidated by staff, and then I will ask the questions. Dr. Bath will be our first panelist who will make her presentation, followed by Dr. Casillas and Dr. Nichols. Dr. Bath.
Thank you, Susan, for such a great introduction. I'm going to share screen. Okay. All right, well, thank you, everyone. And I want to start actually with a little interactive feature, because I thought that that would be good for us to really kind of anchor this talk, because I was asked to do a mashup of social determinants of health, thinking about structural racism, thinking about intersectionality, and relating it to my work as a child, adolescent, and forensic psychiatrist working with juvenile justice involved youth and youth who are also in the child welfare system both of whom have histories of commercial sexual exploitation. So unfortunately, I can't see the chat well, but how many people recognize this woman here? And maybe people can actually raise their hand. Oh, good, I see in the chat, great. Okay, yes. I'm only seeing one person, okay, yes. Participate. So who is she? You can put her name. Gabrielle Petito, yes, okay, very good. Great. All right, so now I'm going to go to the next slide. Now, how many people recognize who this woman is? So I'm getting some yeses. Okay, this is Breonna Taylor. Okay, so for those who don't recognize her, all right, and so, and it's okay if you don't, because now you will. But there's a discrepancy, right, in terms of who we see and who we don't. Okay. How many people recognize this woman? Oh, Dr. Dicker is in their house, everyone. How many people recognize this woman? Seeing a lot of no's. Okay. So this is Centoya Brown, and she was just 16 years old when she was sentenced to life in prison for the murder of a man she claims bought her for sex. She was homeless, was a runaway, and was in and out of the both juvenile justice system, child welfare system, survived multiple rapes, sexual assault, was forced into commercial sexual exploitation, and was sold by her trafficker, cutthroat, who regularly sold her for drug money. And she was recently, her sentence was commuted by the state governor in 2019 after serving 15 years. But basically, she had been tried as an adult and was sentenced to life, without parole. And so her story is pretty fascinating. She wrote a memoir, but this is an example of someone who has intersectional identities and someone whose story we don't know. And so the news media had spoke about this when Gabrielle Petito's story was gaining a lot of traction. And there's been a study about this in the research, also known as missing white woman syndrome, but there are disparities in terms of who gets attention. And I bring this up because so many victims of commercial sexual exploitation are children who are often forgotten. There are youth who are in the juvenile justice and the child welfare system, and they're disproportionately Black and Latinx and Native American. And so their experiences are racialized. And so it's estimated that Black children are actually 35% of the missing children, but receive only 7% of the media attention. And so Kimberly Crenshaw, who as a UCLA legal professor, she coined the term intersectionality, as well as the hashtag Say Her Name. And it's really to reflect the ways in which various forms of inequality actually operate together and exacerbate and potentiate each other. We tend to think of race, gender, class, ableism as all separate, but they really sort of intersect and overlap to amplify risk. And so taken another way, Audre Lorde says there's no such thing as a single issue struggle because we do not live single issue lives. And so this is so important when we're thinking about people with marginalized status. And so keeping the intersectional framework in mind, I want us to think about this wheel of power and privilege and reflect on our own identities, but also this talk is really thinking about social determinants of health and thinking about how racism is also one of those determinants and how those also relate to health inequities. And so in the populations that I work with, these are some of the most marginalized. So on this access of power and privilege, these are some of the people who have the most marginalized identities. So they're most vulnerable to these structures. And they're often in situations where they are vulnerable to structures that amplify their risk and do not have the safety net. So they are living in housing that is, let's say zip codes determine health outcomes. Their health outcomes are such that they have less access to mental health services. Their educational access in some of the school districts they are in, they have less access to special ed services. They're in neighborhoods that have higher concentrations of poverty. So all of these things matter for people who have more marginalized identities. This is another way of looking at how these different structures sort of shape the marginalized status and amplify risk. And again, looking again at intersections of social determinants of health, identity, and location, and how these sort of synergize to amplify risk. And so when thinking about this for girls in particular, which is where my work comes in, it's really important to understand some of the histories around commercial sexual exploitation. So what is it? It is a form of child abuse. These are youth who should be considered victims, not criminals. And it's really exchanging anything for sexual activity for anything of value. So it could be money, it could be housing, anything regardless of force, fraud, or coercion. And it is big business. It really matters for us in California to think about this. California is the #1 hotspot nationally, and Los Angeles actually is the #1 city out of the 13 top cities identified by the FBI. It's estimated that anywhere between 100,000 to 300,000 youth are impacted by commercial sexual exploitation. This is Polaris data from 2019. And one of the things that I want to highlight, because it says only 3,021 victims identified, but this is the trafficking hotline. And so the numbers are always an underestimate because this is just people calling in. So most of trafficking is clandestine and not captured. And, again, it's big business. It's considered to be over $31.2 billion. And why this connects to health and to marginalized populations, that most of the youth who are commercially sexually exploited come from foster care homes. And so Mayor Garcetti did a report in 2015 and found that, of victims who were recuperated, 59% had prior histories in the child welfare system and 92% were of African-American descent. That's the picture of LA. That picture is replicated across the country, not to the extreme in terms of Black disproportionality at the 90% rate, but certainly it is a disproportionately racialized phenomenon, as well as child welfare system involvement. And so when we think about the youth who are impacted by commercial sexual exploitation, and I want you to think about intersectionality and also think about the power and privilege wheel, it's really thought that the average age of entry into the life is between 11 and 13. And these are youth who are experiencing homelessness. They're disproportionately youth of color. LGBTQ youth are particularly vulnerable because often they may be kicked out of their homes. So they're on the street. It's estimated that if a youth is on the street within 48 hours, they're likely to engage in survival sex, which then puts them at risk for exploitation, and youth with histories of abuse or prior victimization. So you see that when we think about the prisms of risk, right, these are youth who are very vulnerable. And so my interest is really that this is a population with great public health significance. They have some of the highest rates of STIs and pregnancy of adolescent populations. And of course, substance use, which often traffickers will get the youth addicted to substances in order to have them be more cooperative, Sometimes youth then, once they've started using, then are using the drugs to cope. Sometimes that's a risk factor for entry into the life. And then of course they have higher rates of mental health disorders, trauma, often pre-existing trauma. And then they're often moving between justice and child welfare systems. And so all of this is at the backdrop of adverse childhood experiences, which really, if we think about different social determinants of health, these ACEs, abuse, neglect, and household dysfunction, we think about the populations I'm talking about, they have all of these ACEs and more, right? Plus they have the other sort of high intensity social determinants of health. And so thinking about specific reasons why I became interested in focusing on their reproductive health, well, one, girls who are in the child welfare system really have super high teen pregnancy rates, unintended pregnancy rates. Teen pregnancy rates have actually been going down, but not in the juvenile justice population nor child welfare population. And particularly in LA County, 40% of teen mothers reported histories of abuse and neglect, and 20% had substantiated child maltreatment reports. 1 in 4 girls in foster care are at risk for having pregnancy. And among those who have one birth, many, close to a third, have a second birth while still in their teens. And many of those children, unfortunately, also end up being in the child welfare system. So there is intergenerational system involvement that comes at play. In terms of sexual risk-taking behavior for justice-involved youth, it is equally stark and dispiriting. And so justice-involved youth have really high reproductive health needs. Their STI rates, sexually transmitted infection rates, are 2 to 3 times the rates of non-incarcerated youth. And they also have, several histories of adverse childhood experiences before entering the justice system. So all of these patterns and some of the studies that my lab and collaborators have done, we realize that they're experiencing higher engagement in sexual risk-taking behaviors. They're using drugs and alcohol, sometimes in a coercive situation, and sometimes they're in their relationships. They're having inconsistent condom use. And so we really wanted to disrupt this cycle and really equip them with skills. And so we thought about this framework of intersectionality, but really applying it towards reproductive health needs and really trying to work with the youth and thinking about also structures that decrease their access and how to sort of community partner with the youth to change outcomes. And so what we did was, in addition to having youth sort of be centered, because often their perspectives, wish, wants, and desires are not, and it's often authorities, doctors, the courts, caseworkers telling them what they should do. We partnered with different entities around LA County, including county agencies, and we really queried the youth and said, hey, how do you want services to be in place, and what type of services do you want? And they told us. And so we basically co-developed, adapted an evidence-based curriculum called Making Proud Choices. We rebranded it as My Body, My Choice. And what's unique about our adaptation is that it's really survivor-led and centered. And so we really have youth with lived experience who are not only facilitating the intervention, but they really help write the language. In the intervention, we made the intervention trauma-informed. We added a substance use module because substance use is part of sex for adolescents, unfortunately, many times, and that impacts their affirmative consent, which then puts them at risk. And so we did all these different things. And we also did something called participatory informatics, which is really thinking about digital technologies and trying to leverage them using mobile technologies and trying to leverage them to really change outcomes. And so our intervention really has 4 main components, really focused on increasing knowledge around sexual transmitted infection prevention, substance use, pregnancy prevention, beliefs and attitudes, and really teaching them negotiation and refusal skills, how to use condoms, and practicing reinforcement and support. And I should add that the courts, for many of these girls who are heavily court involved, the courts tend to care about substance use treatment, mental health treatment, but never about reproductive health. And that seems to be a missing link, because they really need those services because they're so at risk. And so this is just a snapshot of our study timeline. We're actually just finished our second round, but the youth have really enjoyed it. Essentially, they get baseline. We follow them at 1 month and 3 months. And what's neat, I think, that we do is that we, in between the first and 3 months, they actually get reminder text messages. So they're constantly getting chances to practice some of the skills. In some of the co-development, we found different GIFs and memes digitally that they would like and use. And so we use a lot of gamification in the process. And so that is my study. Thank you so much.
Hello, everyone. It's nice to be here. Thank you, Dr. Bath. That was amazing. I learned so much. I always learn so much from you. I'm going to share my screen. One second here. All right. Well, again, hello, everyone. My name is Alejandra Casillas, and I'm a faculty member in the Division of General Internal Medicine and Health Services Research. I'm also a primary care physician at UCLA, as mentioned, and a physician at the Venice Family Free Clinic, the largest free clinic in the nation, where we actually serve a large proportion of low-income, immigrant, and limited English-speaking population. And I spend a large amount of my time conducting health equity research, mostly in patient communication. And so just so you can get to know a little bit about me, why do I focus on health equity? Well, most of all, because it's really personal. So I was born and raised in an immigrant neighborhood of Los Angeles, where really early experiences with the healthcare system motivated my interest in health disparities and inequality in general. A fun fact, or not so fun fact, so my mother gave birth to me at the old UCLA hospital back in the 1970s. And she can still recount her experience of being a patient in labor, being alone with no one with her to speak her language and or translate what was going on during what became an emergency childbirth situation. So it was clearly traumatic for her, because she still talks about it today. And I can talk about the many experiences for other people like her in my family, in my community, and also in my patients throughout my training and now in my career, who have had to lead out these experiences as well, feeling like this, not getting high quality of care because of the color of their skin, their education level, or because of the language that they speak. So my life goal has really become, has come to this point where I would like to really focus on improving the lives of these underserved patients who lived the very same financial and social struggles that I witnessed in my own family, and those who suffered the consequences of poor care and poor access to care due to these social inequities. So just to define a couple of terms that are important. So we're all on the same page, and I'm glad the social determinants of health were already defined for this cohort. So health equity, as defined by Healthy People 2020, which is like the guiding light for researchers and policymakers when it comes to thinking about the health of our nation. Health equity is the attainment of the highest level of health for all people. And achieving health equity requires valuing everyone equally, with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities, where healthcare disparities alludes to differences in health that are not only unnecessary and avoidable, but in addition are considered unfair and unjust. So really, when we're talking about healthcare disparities, we're talking about healthcare inequities that are really rooted in injustices that are embedded in our history and that are embedded in our contemporary structures. There are many frameworks out there that can be used to understand the origins of health disparities. This is a model that was developed by Kilborn that describes the interplay between various determinants, various factors in different categories that then play out in the clinical encounter. So these factors in turn are embedded within a healthcare system, like you can see up here, whose structure, organization, financial incentives have the potential to either facilitate or deter a patient's ability to obtain equitable care that they are seeking. And then these in turn are embedded in the patient's community, the patient's social network, and then generally also embedded in society with its societal powers in terms of influencing all these factors coming together. Usually when I give this talk, I talk upon many aspects of social determinants and how these various factors come together at different levels of healthcare. Today, the time is short, so I'm only going to touch upon a couple of examples and focus on the area of communication where a lot of my research resides these days. So just because we're going to focus on communication, I wanted to define for you the important concept of health literacy, which we define as the ability to obtain, process, and understand basic health information and services needed to make appropriate health decisions about oneself. And really, health literacy is important because it affects people's ability to navigate the healthcare system, which includes filling out complex forms, even just locating your doctor, knowing where to go in a building, getting there on time, figuring out what services, what specialty care you need, understanding what kind of specialist you're seeing. This is all part of health literacy. Health literacy also affects people's ability to even share their personal information, communicate with their provider, share their health history. These are all very important in terms of making healthcare decisions that are appropriate for the patient. Health literacy also affects a patient's ability to engage in self-care and chronic disease management, maybe, and I'll stress this later, in a system that was not built for them. So this is a very important factor to remember. The other thing about health literacy that we have to think about, it's not just reading and writing, but also encompasses the notion of numeracy, which is the ability to understand mathematical concepts such as probability and risk and timing and dosage of medications. So obviously, there's a lot of interplay here, and health literacy is very dependent on individual and systemic factors. With individual factors, you think about education level as being the big ones, one of the big ones, health knowledge, basic health knowledge. Language is one of the biggest ones that we recognize, and a lot of the research that I do is focused on language as well, and then culture as well, and the rapport that you build with your provider. And so I'll talk about a little bit about that in the next slide, in the next couple of slides. And then as well, one of the big things that impacts literacy or the effects of literacy are the resources in the healthcare and public health systems, most notably having documents, having healthcare resources at the reading level for patients that are appropriate, having resources in different languages, having translators and interpreters present in the healthcare facility, the communication skills of the clinician and the team, the welcoming aspect of the clinician and the team, and also the demands of the situation and context. We often see that in under-resourced settings where we see many vulnerable patients. It's just an overburdened setting that doesn't have the resources in place to address the different languages and the different needs for the population. And then that's where you see quality of care really suffer, unfortunately. So I talked about patient rapport in the last slide. And one aspect of that I really wanted to highlight was this whole aspect of patient-provider trust. We know that communication that is rooted in patient-physician trust is associated with appropriate care processes and better patient recall of health information, and higher patient satisfaction. And you may say, well, these are not healthcare outcomes, and why do we really care? Well, we know that these are very important mediators of health status and improved health outcomes, particularly in patients that have chronic diseases like diabetes and hypertension, which are very prominent in vulnerable populations. So this is why patient-provider trust is such an important part of communication. And on that note, I wanted to show you how racial, ethnic differences can play into this whole concept of patient-provider trust, which, as I said, it's an important mediator of healthcare outcomes. So this is a study from the community tracking study in the late 90s, but the results ring true today, which examined geographic variation in mean distrust in physicians amongst white populations, Black populations, and Hispanic Latino groups for major US cities. So basically what you see here is that the more skewed to the right that you are, the higher level of distrust in that population for that given city. And if it's complete, if you see the black dot completely to the right, not even crossing the dotted line, that means that this is statistically significant. So what can we say about this graph? Well, clearly we can all see that amongst the Black population and the Latino population, we have much higher levels of distrust in physicians in those groups. And if I point you to Los Angeles, California, we are off the charts in terms of the distrust in our Black and Latino populations compared to the white population in Los Angeles. And so again, why is this important? Well, as I said before, we know that trust is an important component of good patient rapport and better relationships between physicians and patients, and then can mediate healthcare outcomes. And I wanted to also highlight this study because, you know, often when we say, well, you know, the patient doesn't trust, it's on the patient. Well, we know that there's a large history of injustices in our healthcare system that obviously have a lot to do with that level of distrust. But even in our contemporary society, even recent studies have shown that we don't do much to help this. Studies have shown that in visits with ethnic minority patients, physicians do this. They exhibit less nonverbal attention, less empathy, less courtesy, and less information giving. They adopt a more biomedical communication style. They spend less time providing health education and just chatting and being friendly with their patients and answering questions, and they're more verbally dominant. So we as physicians, even physicians who are from minority backgrounds, don't do much to help the situation. And this is something that we have to take into account as we try to provide care for these traditionally vulnerable populations. I wanted to bring up something that is also very relevant to communication these days, and that is how COVID-19 has really changed healthcare communication, at least in the last year and a half, and probably from the future. This slide is from a colleague at UCSF who's doing similar work as me. And here we see that basically at the outset of the pandemic, the number of visits, basically it flipped the switch. It was primarily in-person visits before March 2020. And as soon as the pandemic started, the majority of visits switched to telehealth. Now we're starting to see more of a blend of in-person and telehealth care. But what happened throughout the pandemic and even up until now, we're seeing that visits, in-person and telehealth visits from vulnerable populations, people who are older, who are limited English proficient, low income and immigrant populations have dropped even more so. So when we talk about expanding access via digital health, and it sounds really great, if we don't have the proper preparation and considerations for other populations who are not in the mainstream, we're actually limiting access even more so. So we have to think about that. We're actually limiting access even more so to patients where the system has not been built for them, right? We need money. People need money for devices. People need money for good quality devices that can connect to a video visit, that can connect to a patient portal. You need money for internet at home. Most platforms are still English only, and maybe if they're in another language, they're in Spanish, but not many of them. So the system is not built for other patients other than those that are in the mainstream. So basically what is happening now is with this transition and with making care more accessible through telehealth and digital medicine, we're actually creating new disparities in this era, what we call digital health disparities. And this is largely where I spend my time these days, partnering with the LA County Department of Health Services, which is the Los Angeles safety net or the public health system for Los Angeles County, working with community partners, frontline stakeholders, people in IT, and thinking about how to develop digital health tools that are more meaningful and accessible, particularly for patients who are limited English proficient in the safety net of Los Angeles. And this has been a great endeavor. And I think what we've learned is that that the system really has to change, and the system has to be rebuilt to serve the patients that are the most vulnerable and the most marginalized. And I think I want to end this talk by just saying that this whole concept of changing the system for our patients and not putting the onus of social determinants on the patient themselves sort of illustrates the evolution of how we've thought about disparity. So, you know, and I know that people often put up these slides on equity, equality, but I want to show you how I think we've evolved over time in going from just basically describing differences and disparities, describing the inequalities of the unjust tree here, the bent tree that clearly favors one side over the other, to then saying, okay, well, now we have to give everybody, you know, an equal chance and providing a ladder, providing an equal ladder. But we know that's not enough because, again, the tree is built wrong, right? It's not going to work. So we've moved towards equity, which means meeting people where they are and giving them what they need so that they can access what they need. But I think the true form of liberation in healthcare from these inequities will come where we can fix the actual tree so that it stands up straight and it doesn't bend unjustly in any given direction. And so where our patients are able to get what they need in an equitable manner. So thank you. It's been a really great pleasure speaking with you today, and I look forward to the Q&A.
Thank you, Dr. Casillas. That was an outstanding presentation, and yours as well, Dr. Bath. And good evening, all of our participants to this very, very important program. My name is Dr. Lisa Nichols, and I am not only a physician, I'm a mother, I'm a daughter, I'm a grandmother, and I'm a Black woman who has had children and have seen women suffer during the pregnancy, delivery, and postpartum period simply because their skin was brown. I've dedicated my life experience, and now I realize it's been quite a few years. It's been 30 years since I've been practicing medicine. And I say I do what I love, and I love what I do. But at this point in my career, I recognize it's very important to place myself in a position to be able to help younger physicians to be able to understand the breadth of what I do in regards to delivery of care for women. And that's been my primary focus in medical education. So I'd like to share my screen at this point and see if we can. Okay. And okay, so our topic is advancing healthcare for all. And we recognize the social determinants of health really influence, you know, how a person can really enjoy good health that's supposed to be something that is available to all of us, not necessarily as a privilege, but in fact as a right. I oftentimes look to people of greatness, and Martin Luther King is certainly someone I truly admire, and I'm certain many of you feel that same way too. And he said quite eloquently, of all the forms of inequality, injustice in health is probably the most shocking and the most inhumane. So we, at this time and juncture in 2021, really need to formulate our thought process in regards to how we can move things better in our country. And as Dr. Casillas had indicated, the COVID pandemic really unlifted the veil in a most profound way in regards to some of the inequities and the injustices that we see. My particular focus is going to be on maternal mortality. And many of you may not be aware, but maternal mortality is a big problem for our country. In comparison to other what they term as industrialized or westernized nations, we're at the bottom of the pit. We can put people on the moon, we can do all these other miraculous things, but nonetheless, we have not figured out how to really save women from dying as it relates to a pregnancy experience. So I thought it would be important for us to go through a few definitions as I talk about maternal mortality. And we're talking about maternal mortality that oftentimes reflected in statistics only speaks within a framework of 42 days as it relates to the actual delivery and the time frame thereafter. But there's a scope of incidents that actually can occur in association to pregnancy that are quite severe and quite problematic. 52% of events such as maternal death actually occur after the baby is already out. So you say to yourself, I've gone to the hospital, I've had my baby, and I'm sent home, and I'm thinking I'm safe. But many women aren't safe. And the women that I'm going to be specifically focusing on are women of color or Black women in this country. The statistics now indicate that Black women are 3 to 4 times more likely to die in relationship to the childbirth experience. And I want to share a story with you that is so close to my mind. It's one of my patients, a lovely couple, very intelligent, very responsible, very health literate, and just beautiful people. At one of the visits, the husband was there with his wife, and he started crying during the visit. And I thought everything was going very well. She's not having any complications. We're very happy about the growth of her baby. All is well, and we're just anxiously awaiting the special day. But he shared with me, I've been reading these stories, and I do not want anything to happen to my wife. She is the most precious thing in my life. Please, Dr. Nichols, don't let her die. Maybe it's best that we just stay at home and don't go to the hospital. So of course, this is pretty startling information. And as a result, a lot of women had come to me saying that I think I'd rather take my chances on having a home birth as opposed to going to the hospital because of the statistics that have been there. So this is not a new problem. If you think in terms of what things looked like in 1916, there's always that gap in regards to what actually could occur during the labor and delivery and that time frame thereafter for Black women as compared to white women. This statistic clearly delineates that this ratio has stayed very steadfast and the same over the years from 1916 and actually increasing as we look in the years of 2000. So you're saying this is not a new problem, Dr. Nichols? No, it's not a new problem. And it's something that has deeply troubled many of us in the healthcare field. So you're saying, well, all of these determinants of health in regards to things that are happening in our community with regards to poverty, housing, lack of transportation, education, all these factors that we know pour into the subject matter of social determinants of health. But even when we consider these factors, there still seems to be something that happens with Black women compared to white women. And as this slide demonstrates, even higher education does not protect Black mothers from pregnancy-related death. So some of the statistics that we've seen, a young woman that is white, that may have a high school education and may have a lower social economic status, has a greater probability to having a safer birth and delivery process, as well as not succumbing to death, as compared to a college-educated Black woman that has what we call means. In other words, there may not be any economic barriers in regards to being able to select a hospital, select a doctor, and really have control in regards to what's happening during the birth process. And there's specific examples that some of you may be aware of in regards to some prominent noteworthy and individuals that we may be aware of, such as Serena Williams, outstanding tennis player. There is Shalon Irving, who was a decorated person in the military and also in healthcare. And of course, Kira Johnson. Kira Johnson was another beautiful, educated woman that actually delivered over at Cedars-Sinai, but unfortunately had an untimely death after a complication that essentially was diagnosed late. And she ended up actually dying. Her husband has really been a very staunch champion in regards to making really strong awareness in regards to her case and what had happened. And specifically for those of you who may not know, there was this noted problem after she had the cesarean delivery in the recovery area, which her husband was astute enough to recognize perhaps would require some immediate attention. However, she was ignored. He was shushed away by nursing staff, and there wasn't really immediate responsiveness to what he had recognized that didn't seem right with his wife. So finally, there was an awareness what would happen. She was rushed back to the operating room, and basically she was bleeding internally, and they were not really able to control the bleeding, and she died. So that's a quick synopsis of that. And he's probably a better person to tell that story. And you all can go to YouTube and Google that. And it's the story of Kira Johnson. And the crux of it is oftentimes Black women are not heard. Their partners are ignored, and there isn't true advocacy in regards to what can happen to them during the labor and delivery process. So what happens? What are some of the causes? Well, cardiovascular disease is probably the leading cause for death during the pregnancy-related era. Certain conditions such as hypertension, blood clots, and the like, and that's what Serena Williams had, are very, very dangerous things. But then there's cardiomyopathies, or what we call weakened heart muscles, that actually occurs during the postpartum period. And in order for that to be recognized, the patient has to have access to the doctors and healthcare that would be able to note when this problem is part of an issue for her and be able to do the appropriate interventions. But if you see a situation where healthcare is not accessible to a woman after 6 weeks by virtue of insurance issues, then there's a lost opportunity to really save her life. Hemorrhage is one of the leading causes of maternal death if you look at what's happening on a global basis. But hemorrhage is something that we here in California really were able to make a big difference in regards to doing an intervention to help to really lessen that probability during the labor and delivery process. And that's by doing certain things, which we call team bundles, and huddling and doing certain protocols to be able to manage women that may be succumbing from hemorrhage during the labor process and delivery. So now this slide, I think this may speak to something that Dr. Dicker is dealing with. This came out in the Green Journal, which is our big think tank for the American College of OBGYN. And as you can see on this slide, the hemorrhage and placental disorders are cause for death, maternal death, hypertensive disorders, and sepsis is known. But look what is the highest insofar as what was reported during this time period of 2018-2021. Homicide. That's startling. It's startling. Violence, gun violence. Gun violence is a public health emergency. This is something that all of us really need to appreciate in regards to how this impacts health for our community. This is a very, very troublesome and problematic aspect that we're dealing with in our country that other westernized countries do not have as it relates to gun violence and homicide. Suicide, depression, anxiety, these are all other issues that we're dealing with that relates to the labor and delivery and postpartum period. So what, why, and how? What can we do about all of these things? All these statistics that myself, Dr. Bath, Dr. Casillas has presented to all of you today is to keep you in a sense of awareness about what's going on around us. One of the issues is clearly access to treatment, being able to get people in the right place at the right time with the right people, all right? But the quality of clinical care is very much related to if we're able to communicate with our patients, if we're able to appreciate and respect the cultural space, the language space, where they are in their lives, so we can really give them the kind of care that they need and deserve. That means we may have to try to do things in a different way and maybe in a non-conventional way to be able to impact the problem. And then once again, the effects of structural racism. That one slide that Dr. Casillas put up really delineated how wide the scope of that is and how many years that this really has influenced what we see in our healthcare system. Specifically for OBGYN, for those of you maybe historians, there's a doctor by the name of Dr. Marion Sims. He was actually referred to as the father of gynecology. Dr. Sims was a physician, and I guess he called himself a clinician scientist that really based his observation and his work by performing surgeries on slave women at the time without anesthesia, all right? He had other people that participated in these events with him, and actually he became quite wealthy in regards to his activities during the slave market by doing these things and performing these procedures. And specifically what he was doing was trying to find out a way how to repair obstetric fistula, a fistula that occurs as a result of childbirth, which is unexpected communication between the bladder and the vagina or the rectum. He would create these problems for these women and then try to determine techniques and strategies how he would repair these things. And he would do this without giving them anesthesia. This is a very barbaric practice. But this stems back to some of these ideologies and thoughts and beliefs in regards to how women of color deal with pain. It stems way back to some of these things that so-called was put forth by the father of gynecology. Over a lot of the medical school and college campuses, the statues and things that were erected in his honor have now been taken down after the history has become unveiled in regards to what he actually did in the scope of medicine and gynecology. And then we talked about the social determinants of health, and this could be a discussion that go on and on and on and on and on. But transportation is something key in regards to women being able to make their appointments, be able to pick up their medications, even if their medications are low cost or free. She still has to access the system to be able to get the medications. And if that is not feasible because she's working 2 to 3 jobs, or she's riding 2 to 3 buses, or she's having childcare issues, or these kind of things, that really influences what ultimately is going to be the outcome of her care. So, I just want to close because I would hope that we'd have time for question and answers for all of us. But, this is another person I greatly admire, and I'm sure many of you do too. And what he essentially is saying in this quote, that we're seeing all these things, we're talking about these things, we're reflecting all these things, but the change really has to come from us in community. We can't expect someone else to try to figure out how to solve these problems. And we're hoping, myself and the other doctors on this panel, that we can look to all of you as being partners in regards to all the work that we're doing with regards to direct patient care, with regards to educating our young physicians and medical students, and doing the important clinical research to really impact and how to do things better. So that's what I've had for you today. And, I thank you for that. I think I'm going to hand it over to Dr. Dicker. It's so good to see you.
Oh, thank you so much, Dr. Nichols. But my job here is easy because the framing has already happened in such a big way, and I want to give people the opportunity to ask some questions and have some dialogue. So I have already truncated my presentation, and so if you can, I'll just share my slides really quickly here with all of you. And tell you in a few minutes my motivation and a couple of really important initiatives. My motivation is this. This was one of my patients a few years ago who suffered a gunshot wound to an area that feeds the nerves down to the hand. And as a result of this right-handed gentleman's injury, he learned how to paint with his left hand from a volunteer at our hospital-based violence intervention program who had actually previously lost his son from gun violence. So what motivates me is to see this painting and the extraordinary determination, but also the incredible pain. And Dr. Bath mentioned the ACEs. And if you just look at this wonderful man's eyes, about the ACEs without even reading about it. So my motivation is my people, and my people keep getting shot. And sometimes as a trauma surgeon, which is what I just experienced and why I was late, you feel like you're standing at the bottom of the waterfall and you want to climb up that waterfall. Unfortunately, we're starting to do that. And already, as I mentioned, the framing has been set by my incredible colleagues here around structural racism and the social determinants of health. And as a result of realizing and recognizing the importance of cultural humility and credible messengers, we started hospital-based violence intervention programs about 15 years ago in this country. And now we have a network. And it is absolutely predicated on the fact that we need to integrate social care into our medical care systems. And as Dr. Nichols had brought up, our victims of violence it is a public health emergency, and our young, mostly Black men and women of color or men and women are dying as a result of this daily, and is absolutely intolerable. So what's the current state of health inequities in Los Angeles? I'm going to speed through this. You all know about how redlining in the 30s set up such a system by which we are unfortunately still seeing the results today. So we see life expectancy, for example, if you look at Malibu, you're looking at more than 90 years. But if you look at Linwood and Compton and Watts, you're looking at a significant disparity there. And we see this in terms of the social determinants of health. And not only chronic violence, but other chronic diseases, it implies to us, and we know now that we have to move upstream in order to not just be reactive, but proactive about really addressing the underlying issues. And I'm going to speed through this because you already know about the social determinants. So here at UCLA, we have done a few things. Through the Program for the Advancement of Surgical Equity, we are piloting a trauma-informed care curriculum because we know that in our trauma bays, we lack some of the really critical emotional and mental health support for our victims of violence. We have to be able to have the cultural humility and understand and empower our patients to be part of the system of care, not just the delivery of medicines and surgery, but really to create a system of care that's a partnership with our people. And then we also have health equity and translational social science. This is the newest theme at DGSOM. And we really think of this in terms of a total paradigm shift in how we think about structuring programs that address the social determinants of health and how to study it, which is as important. We want to make sure we understand our pitfalls if there are some and fix them along the way. So the vision of our health equity and translational social science theme is to create equity-centered patient care models, just like a hospital-based violence intervention program, in concert with research that centers social sciences, humanities, and community collaboration. And our advisory board speaks to that. We have community members, we have members from the community at UCLA on both North and South campuses as part of our family at HETSS. And our mission is establishing translational social sciences and humanities research as essential sciences in the study of health inequities and delivery of equity-centered patient care, and to build inclusive and scholarly learning environments with social scientists. But really the most critical thing is that we bring in our community for the critical reciprocity and value that is so necessary in everything we do in health equity research. We want to foster and engage collaborative groups in social sciences and community partners. And as I mentioned, develop equity-centered patient care models. And I'm going to speak to that in just about 10 seconds. Advancing the development of equity-centered patient care models with translational social science, as I mentioned earlier, that is really critical for us to really understand the value of the programs we develop and where our pitfalls lie. And just to say, you know, this is a great example of understanding what it means when we write discharge to home for one of our patients who has been violently injured. It's easy to write that order, but what if our patient lives on the 3rd floor and has no elevator and has a leg injury? It's hard to use public transportation. This person can't afford the nutritional supplements that you just easily wrote for discharge. He's unable to get wound care and supplies due to the cost, physical therapy, and all of his appointments are on all different days. So all these things you can get a sense like, wait a minute, and then what do we say if they don't come? That we say that the person is, quote, non-compliant. But if we really have an underlying understanding of all the challenges, the social and mental health challenges to our individuals, we can take action and build systems of care that are much more comprehensive. 2 main initiatives at Health Equity and Translational Social Science is building an institute, a biosocial research institute for justice and health that would focus on research and theory development around health equity and those interventions that I mentioned in that comprehensive care spirit. And then also around teaching and training, we're fortunate to be at such an incredible place with students and trainees who really want to take the helm and are invested and passionate about disrupting health equity and disrupting the structural racism that is so pervasive with our patients. So with that, I'll stop because I do want an opportunity for us to have a little dialogue. Thank you so much, and an honor to be here with my colleagues. Thanks very much. So I am going to turn to some of the QA, and I know Dr. Bath, you have to go. So I'm going to ask you a really quick question if you have a moment. This is from our attendees. How can we as individuals recognize a child or woman who is being trafficked? And how can bystanders best intervene?
Yeah, it's really, there's some great tools that are out there. There's a tool, and I'll put it in the chat. It's spelled CSE-IT. So see it, but like CSE, Commercial Sexual Exploitation Identification Tool. And it teaches, it's mostly for providers, but also for people who may be functioning as court appointed special advocates, who would have some sort of connection, but there can be telltale signs. So if you notice a young person is with someone who's much older, that person seems overly controlling, domineering. Maybe a young person is completely inappropriately dressed, particularly for the weather. Sometimes you'll see, and some of my colleagues who work in the ER, they'll probably know that, sometimes girls will come in completely, wearing, barely anything, with really flashy lingerie, sometimes inappropriate tattoos. Some of the tattooing might be on the face. I've seen, unfortunately, it's like branding, where some of the traffickers were actually brand the girls, but all of those types of things would be potential signs. Unusual hunger, unusual patterns of injury. These would often be things that I'd say that lay people may not come into contact with as much. As I think one of the challenges, and when we think about sort of the positionality access and the power wheel, many of us have privilege and aren't in environments where we're really interacting with that population at all. There's so much distance from people who are upper middle class and educated and in certain environments, from youth who are justice involved or youth who are in the system. So they're really not seeing them. And so it allows some of the structural aspects, allows them to be more invisibilized. So it's harder to even see them unless you're working in healthcare settings or social service settings. But if you do, see these youth on the street, and depending on where you're driving, yes, but don't expect necessarily that the youth will want your help, because many times, unfortunately, the youth reject the help. They don't necessarily know or believe that they're trafficked. The traffickers are really expert at grooming the youth. These youth often, because of their histories of trauma and abuse, have really fragmented attachment histories, and so tend to be really attached to these traffickers who they mistakenly feel are providing the sun, moon, and stars to them. And so they may, just like domestic violence victims or intimate partner violence victims, may not be ready to leave at the first, second, third, 100th time. We as providers or people who mean well can't personalize it if our, well-meaning interventions and efforts go unwelcome. And so we just have to meet people where they are, not ask them salacious details about their trafficking experience. It's another thing we say, try to fix your face. Because sometimes when youth are telling us things, some of it's so horrific, but we really need to have neutral posture. And they tell me and to tell other providers to just not be judgmental, because it's really hard, I think, as physicians, to not be prescriptive, or as a parent to not tell them what to do, and that you should do this or you should leave, and just sort of, allow them to engage in what we call shared decision making. So much of their choice is taken away from them. They don't have really much autonomy because of all the systems that control their life, whether it's the exploiter, whether it's the history of maltreatment or justice juvenile justice, child welfare system. So allow them to engage in shared decision-making if you're in that situation. So I hope that answered.
Thank you, Dr. Bath.
I can stay for a few more minutes. Yeah.
Oh, great.
Yeah.
Excellent.
Yeah.
Dr. Casillas, if you have the time, there is a question I think would be great for you to address. How do you handle the language barriers that exist in diverse populations that can impact communication and understanding, especially in the electronic health record?
That's a great question. So I think right now the problem is that we're very, very far behind in meeting patients where they are when it comes to language and when it comes to the electronic health record. So basically what happened with the EHR is that it was built, patient portals were implemented, telemedicine was implemented, but they never really thought about these populations. They never put these populations at the forefront. It was sort of built with a Main Street population in mind. And right now what we're doing is we're doing a lot of catch-up work in working with the vendors to develop platforms that are in various languages. Most of the platforms now, the interfaces are English only, perhaps maybe some with the English-Spanish interface, but when it comes to the actual content and the messaging, all of the other sort of substantive parts of the EHR, it's all in English. So right now, a lot of our stakeholder work, our community work is with engaging the vendors and creating incentives so that these systems are changed, because basically what happened is that there wasn't a lot of incentive for these vendors to produce multilingual platforms. And then it was very expensive for health systems to require it. So it's a lot of backtracking in terms of incentives, in terms of government policies to establish policies, rules, regulations that govern EHR the same way they govern medical forms of all types. You know, when you go to a medical facility, things have to be in multiple languages. They have to be accessible. It's part of the law, but there are no laws to govern the EHR. So a lot of it right now is backtracking and working on policy and working with vendors, working with the government, so that we put this infrastructure in place. We change the system so that we can meet the patients. So that's why a lot of my talk was about reframing the system, breaking down the system, because we can't put the onus on the patient to learn, to get educated, to engage. It's up to us to rebuild the system so that it better serves the most vulnerable, because when it serves the most vulnerable, it will serve all. And so that's what we're trying to do in the work that we're doing in the county.
Thank you very much. Here's another really outstanding question. Are these patients eligible for Medi-Cal, CalWORKs, CalFresh benefits? And have you considered partnering with legal services, attorneys, to help advocate for medical transportation under Medi-Cal, or for changes to CalWORKs programs that would help enable trafficked women to find other ways to gain skills and resources?
That sounds like it's for me.
That sounds like it's for you, Dr.
Yeah,
Bath.
I would say, yes, the county and the LA County Board of Supervisors has been really interested in youth with commercial sexual exploitation, and there are two specialty courts that have happened both in the juvenile justice system and the delinquency system, just because of the need. And so those use trauma-informed multidisciplinary team approaches, and but there's still a lot of gaps between treatment need and receipt, and there's not enough child mental health providers. There's not enough translation of evidence-based mental health and substance use practice or reproductive practice, which is why I'm trying to disseminate my work more broadly, or at least tested into those systems. So youth can access care and treatment. And so usually if you are juvenile justice involved or child welfare involved, you can get services through Medi-Cal. However, there's issues in terms of just having enough providers, right? And all of those connections became even more fragmented with COVID. So a lot of our county funded mental health systems just really, from what I heard from the youth and doing some focus groups with them, they just had longer wait times. Instead of seeing a therapist once a week, you know, some of us see a therapist twice a week. They could see the therapist maybe once every 3 weeks. And so that's really not, you know, they were experiencing a lot of discontinuous care, but there are sort of systems in order to get them to and fro to some degree.
Thank you so much, Dr. Bath.
I wanted to add something.
Oh, I'm sorry. Sure.
Of course. Piggyback on that, because in our work as well, we, obviously a lot of the chronic diseases offering services, and I would just add, in our population, specifically with the undocumented, there's a lot of stigma around accessing these services. And I would imagine with trafficked youth and those that are undocumented, there's a lot of fear and stigma in getting services that are, are sort of services that they should access. And so we should make that note that there is a lot of fear around getting government services for these populations who are undocumented as well.
And can I add another footnote to that? One of the things that's needed too is someone to help them navigate accessing those services. So many times if there are services there, it's very exhausting to sort of, there should be an app for that, right? An app that kind of cross connects those available services to them. Many of the youth I see, they have many different people involved in their life, but those people aren't co-located on a digital platform. If we need anything, we can go online, we can go My Chart, we can find all of our providers, all of our notes, but they don't really have a digital, system to access their child welfare records and who their caseworkers are, or their health records in the same way. And so that's sort of aspirational, but we need sort of the digital divide also affects the health record access so that people can actually have more self-determination and really try to have more health literacy, because they'll know their information rather than having to, take their own notes or write it on a scrap of paper.
Thank you. And I hope we have time for one more question for Dr. Nichols. This one I'll direct towards you. How are you recognizing the issues in the final slide as to when you send a patient home? That was my slide, but who might face enormous obstacles to becoming compliant? Are there issues as to the difficulties in scheduling appointments, home health care, transportation? How do you fix the tree as suggested in another presentation? But any of us can expand on that, so I'm going to turn that to you.
All right, thank you. Well, that's a very important question, because first of all, you have to be aware of what the patient's situation is. Unless you ask the right questions, sometimes they won't give you the answer. So you'll write discharge to home, and they may not be going to home. They may not have a home. So making certain that communication is really clear in regards to what the status of the patient is. But we have our social workers over at the hospital that are excellent. They'll assist us in being able to determine where their needs are. And at the Midwest Center that we have a whole staff of people, health educators and persons who interact with our patients to help them navigate through all of those things. So the key response to that is having your team available to be able to do the right things at the right time.
Yeah, I completely agree with that. And having comprehensive care is the only way really to have real care for our patients. To think that we can just continue to just be reactive, I think we're over that. We really have to bring in credible messengers, have cultural humility, and understand the challenges. So we will stop there. Thank you so much. I'm sorry that I was late, and I'm just honored to share this opportunity with my colleagues here.
Thank you, Dr. Dicker, for coming after the trauma that you dealt with. And thank you to all of our UCLA doctors, Eraka Bath, Alejandra Casillas, and Lisa Nichols, for your time and for sharing your knowledge and informing us more about how community conditions and other factors play a powerful role in determining health and outcomes. Thank you as well to Women in Philanthropy members and our other UCLA supporters for participating in our webinar. And a tremendous thank you to our event staff, Melissa Delgadillo, Stella Plato, Lauren Gutierrez, who help us with all the Zoom meeting logistics. And finally, great appreciation as always to our Women in Philanthropy staff, our director, Melissa Efron-Hayek, and our program manager, Betty Montano, We hope to provide our third in our anti-racism series in March 2022. The specific topic will address what UCLA is doing internally to rise to the challenge of examining and addressing anti-racism and systemic change throughout campus, and we've heard some of it tonight. Look for invitations in your mailbox. Happy Thanksgiving and all the joys and blessings that this season brings. Good night.